Welcome to Dental XP. I'm Dr. Maurice Salama, and today we'll be discussing the regeneration of a deficient area in the maxillary left lateral incisor region. As you can see from the slide, tooth number 10 was decayed beyond the gingival margin, and the decay went down into the canal space, leaving this tooth unrestorable. What we're doing now is simply probing down to bone interproximally and seeing that we're about 5 millimeters to 5.5 millimeters from the contact point on the mesial aspect of the left canine, as well as the distal aspect of the maxillary left central incisor. This is important information, as now we can predict the possible shrinkage of approximately 1/2 millimeter of tissue interproximally down the road. You can see also the bone sounding on the facial exposed a very significant facial bony defect, and we are going to compensate for that with bone augmentation as well as soft tissue grafting. And as you can see here, we're going to first proceed prior to the extraction to harvest connective tissue from the maxillary left palatal region. And what we usually like to do is use parallel incisions from the distal of the first molar to the distal of the maxillary left canine. These parallel incisions are then made elliptically and joined at the mesial and distal aspects. We then could utilize, as you can see here, small microsurgical tissue forceps to help extract the connective tissue from this palatal region. And this is fairly common procedure in periodontal, aesthetic, and implant related augmentation procedures today. And we can usually harvest this tissue very quickly and without a lot of difficulty. The process of suturing the donor site is readily taken care of utilizing horizontal crisscross mattress sutures. This suture allows us to gain hemostasis and to provide for a tension-free and usually a primary closure of the wound space. As you can see here, 2 horizontal crisscross mattress sutures have been performed, and we now have coapted the flaps quite nicely. A broad-based vertical incision is going to be utilized unilaterally to expose the defect environment. Based upon our bone sounding, we were quite sure that we were going to be dealing with the loss of a facial plate due to the infection that occurred around this broken down and decayed tooth. Full thickness flaps and sulcular incisions are going to be utilized, and usually we prefer to hide the vertical incisions distal to the anterior space whenever possible, and therefore a single vertical incision is usually appropriate for the regenerative procedure that we're going to be performing today. Sulcular incisions are then going to be utilized across the midline. I prefer to have at least 1.5 to 2 teeth on either side of the defect environment in terms of my flap dissection. This gives me a broad base to work in terms of vascularity and allows me to fully access the defect environment. I then use a microperiosteal elevator. This is a Boozer elevator to first lift up the interdental papillas, and then a microperiosteal elevator to begin the initial dissection of the flap. This is first done with full thickness dissection, as it will allow me to gain access beyond the mucogingival junction and gain access to the large infection. We're then going to utilize a spoon excavator or back action Rhodes scaler to remove this large infection. And you can see that once we're able to do this, we're then going to be able to access the root and be able to extract it without any difficulty. As a matter of fact, this tooth is missing the entire labial plate of bone and therefore extracted directly labially, and you can see how severely broken down and infected this area was. We now are looking at a 3-wall defect, and luckily enough, because of the bone sounding, we were aware of the fact that we still retain the mesial and distal walls and palatal walls of the defect, but we're entirely missing the facial plate of bone in its entirety. We're then going to utilize, for augmentation purposes, a bioos collagen sponge impregnated with PRGF, platelet-rich and growth factors, a BTI product, and something in protocol that was created by Dr. Eduardo Anitwa. And we are now slowly coapting this collagen sponge into the defect environment. And this is a very nice material to use. It has very good handling qualities, and you can see the PRGF fluid pooling up on the distal aspect as I start to pack the collagen graft into the defect environment. It's very important for us to not over condense this area, but just lightly condense it. And I'm utilizing a condenser. This is a stoma extraction condenser with a bullet and ball tip. And then the layers of fibrin that are created from the PRGF protocol. These are autologous and created from the patient's own blood and can be harvested in layers and utilized as an autologous membrane barrier. So it has a membrane barrier function that allows us to protect the bone graft from the outer flap during the initial healing. And this material gives us about 2 to 3 minutes of working time before it starts to set, and it goes from a yellow color to a pale color when it starts to become more firm. So you can see us starting to adapt it around the BioOs collagen. And this really allows us working time to really shape this and protect all of the bone graft that we have just placed into the area. As I said before, one of the nice things about PRGF is that it's taken from the patient's blood with a minimal cost, approximately $15 to $20 per patient. Because we want a longer-term barrier function, we went ahead and decided to add a collagen membrane. In this case, this is a Memlock membrane from BioHorizons, and we're going to also use the BioHorizons AutoTac kit to secure the membrane. This is an excellent way of securing and stabilizing the membrane, which I think is extremely important as we don't have micro motion or micro movement, which may in fact create a poorer healing of the underlying bone grafted area. So the AutoTac is placed first in between the two central incisors, and then the second AutoTac will be inserted distal to the maxillary left canine, giving us very, very good initial stability of our membrane and long-term membrane function. And here the tack being inserted. This is almost like when you lay down carpet. It actually allows us to place it on very, very nicely. And then we layer on the collagen barrier, not only on the facial aspect, but also over the occlusal aspect. It is layered on, making certain that we can tuck it in under the palatal flap, and it is then layered over the facial aspect of the collagen that was placed first. This allows us now to have regeneration occurring both from the occlusal aspect as well as the labial aspect, completely covered and protected by a resorbable collagen barrier that gives us a long-term barrier function. The fibrin membrane, although very nice to utilize it, has a shorter membrane function. It starts to resorb in approximately 3 to 4 weeks. So when we have large defects like this, I prefer to also utilize a collagen barrier in addition to the fibrin. This is just my preference, only because I realize that the extent of the defect will require a longer term barrier function to protect the bone and to make sure that the selected cells are allowed to populate the area, letting the osteoblasts have access to the area without having to beat the connective tissue and epithelium to that area. Once again, because we have layers of fibrin to utilize, I now place the fibrin membrane over the collagen, again, in a layered approach. The fibrin first, mixed with the bioactive modifiers, then the collagen membrane over the top of that, and then once again the fibrin over the collagen. The final piece of the puzzle is the original connective tissue graft, the autologous connective tissue that was harvested from the maxillary left palatal region. So you can see the layered approach to this defect, completely cleaning out, debriding it, followed by the BioOs collagen impregnated with PRGF, plasma-rich and growth factors from BTI, followed then by the utilization of fibrin and a collagen barrier, Memlock from BioHorizons with the AutoTac, and then followed after that once again with the second layer of fibrin and then the autologous connective tissue graft harvested from the maxillary left palatal region. This allows us to completely correct the defect in its entirety, both the bone as well as the soft tissue nature of the volume of this defect. One of the most important aspects is tension-free closure of any regenerated area. And here you can see us doing split thickness dissection beyond the mucogingival junction, where we have elastin fibers incorporated into the flap. We want to make sure that this flap will be easily moved in a coronal position, and coronally positioning this tissue over the augmented tissue and membrane is extremely important to the long-term success. Once we've created the split thickness dissection, we then can go ahead and utilize Gore-Tex sutures. These are polytetrafluoroethylene or PTFE sutures that are inert and can stay in for quite some time. We go through the palate, then through the connective tissue, and then through the outer flap at the base of the triangle of the papilla. We prefer to utilize this in a vertical mattress suture so that we can keep the interdental papillas at a high position during the initial healing phase. And here you can see, as we're putting pressure on these sutures and starting to tighten them, you can see that we're really coronally positioning the outer flap quite nicely. We're going to utilize these sutures once again for the interproximal areas between the central incisors to co-opt the last parts of the flap. And then the last thing I like to do is close off the vertical incision. And once again, this is done with a horizontal mattress. Here you can see that because we use connective tissue, we don't have to completely close and coronally position the mucogingival junction, which is quite nice. We've stabilized the connective tissue with the PTFE sutures. And this is excellent for us because therefore we really don't have to alter the dimensions of the defect during the healing phase. A Essex tooth replacement device is then inserted, making certain that there's no pressure on top of the surgical wound. And then once we've relieved this before the patient leaves, a final bit of PRGF material, which has been created into a gel, we call it a PRGF plug, is then inserted over the top of the augmented area. This will be left in place for the first several hours as the patient begins to heal and protect this area quite nicely. Once again, the previous slide of the preoperative image of the severely decayed and broken down maxillary left lateral incisor. You can see how we've been able to perform this procedure, and this is at approximately 8 weeks. Post-operative healing, the maintenance of an intact ridge with good mesial-distal and buccolingual volume, as well as an enhancement of the keratinized gingiva. You can see the wound healing with the new bone graft and collagen, BioOs collagen, being incorporated into the surrounding bone. And then approximately 5 to 6 months afterwards, we go ahead and place our dental implant. Thank you for your time in joining us, and we hope you'll follow this case through with us on Dental XP as we place our implant and restore the case to its entirety. Thank you very much. For Dental XP, this is Dr. Maurice Salama.